Assalamu alaikum students, can you hear me?
अस्सलाम वालेकुम सर। अस्सलाम वालेकुम सर।
वालेकुम सलाम। आवाज़ आ रही है सबको?
सर स्टार्ट करें।
ओके ओके, थैंक यू।
आवाज़ आपकी ज़रा कम है, बाकी स्टार्ट करें आप।
अब बताइए, अब आवाज़ कैसी है?
हाँ जी जी, ठीक है।
ओके, थैंक यू।
ओके सर। ये जो सर माइक अपने मुंह के करीब ले आए आप।
ठीक है। Assalamu alaikum students, hope you are doing well. Today we are going to discuss yet another very important topic uh, regarding your exam, that is basal ganglia. So, inshallah, by the end of today's session, you will be able to define
सर आपकी
basal
आवाज़
ganglia.
बहुत कम है सर।
अब बताइए, कुछ बेहतर हुई आवाज़?
जी सर ठीक है।
So we will
ऊंची ज़रा बोलें बस, बाकी ठीक है, ऊंची बोलें ज़रा।
so we will define basal ganglia. What are basal ganglia? What are the different components of basal ganglia? And then we will discuss the functions of basal ganglia. And at the end of today's session, we will learn two very important clinical conditions. And the first one is Parkinson's disease, and the second one that we will discuss is Huntington's chorea, or known as Huntington's disease. So these are the learning outcomes for today's session. So let's begin. So you must have heard this term frequently in your lectures during your physiology and anatomy classes, basal ganglia. So when we use the term basal ganglia, how can we define basal ganglia? These are the masses of gray matter. Masses of gray matter submerged in the white matter of the cerebral cortex. This is the simplest of all definitions. Masses of gray matter scattered within the white matter of cerebrum. And the thing to remember is that basal ganglia is part of the extrapyramidal system that controls the motor activity. Here you can see the figure, the location of the basal ganglia. This is the putamen and the globus pallidus. These are the nuclei of the basal ganglia. Caudate nucleus, another nucleus of basal ganglia. You can appreciate the location. And all these nuclei of basal ganglia, these are
हाँ
made
जी
up of
वालेकुम सलाम।
gray
गुड़िया
matter.
सॉरी, आई हैड टू शट योर फोन कॉल। हाँ हाँ। हाय हाय बेटा, उसको वहां पे आप उसको शौकत मैडम की इमरजेंसी में क्यों नहीं ले जाते? अगर एक्यूट लिम्फोब्लास्टिक ल्यूकीमिया है तो वो तो इमरजेंसी है, इसमें उसको वहां ले जाएं एंड देन लेट्स सी व्हाट हैपेंस।
Okay, sorry for the interruption. So we were discussing these are the gray matter areas, putamen, globus pallidus, caudate nucleus. All these are made up of gray matter, and you can see these areas of gray matter, they are submerged within the white matter of the cerebral cortex. So as far as the components of basal ganglia are concerned, the three primary components that you must remember, they include corpus striatum, and second component is subthalamic nucleus, and the third one is substantia nigra. So when you get the question regarding components of basal ganglia, This is the minimum that you should write. The three primary components: corpus striatum, subthalamic nucleus, and substantia nigra. So these are the terminologies that we frequently use during the description of basal ganglia. And the thing to remember is that this corpus striatum is made up of two nuclei, and these are the caudate nucleus and the putamen nucleus. Sorry, I stand corrected. Corpus striatum is made up of caudate nucleus and the lentiform nucleus. The lentiform nucleus further consists of globus pallidus and putamen nucleus. So there is overlapping between these terminologies. When we use the term corpus striatum, we are referring to caudate and lentiform nucleus, where lentiform nucleus consists of globus pallidus and putamen. Caudate nucleus is considered separately. So these are the components of basal ganglia. The first portion is corpus striatum, which further consists of caudate and lentiform nucleus, where lentiform nucleus consists of globus pallidus and putamen. Then comes the subthalamic nucleus and substantia nigra. And there are two subdivisions of substantia nigra: pars compacta and pars reticularis. These are the two subdivisions of substantia nigra, where pars compacta is responsible for release of dopamine neurotransmitter. The primary secretion from pars compacta is the inhibitory neurotransmitter dopamine, whereas pars reticularis is responsible for release of another inhibitory neurotransmitter, GABA, where GABA stands for gamma amino butyric acid. So the components of basal ganglia include corpus striatum, number one, subthalamic nucleus, number two, and substantia nigra, number three. Where substantia nigra consists of pars compacta, responsible for release of dopamine, and pars reticularis, responsible for release of GABA. And corpus striatum consists of two nuclei, caudate and lentiform, and lentiform nucleus consists of globus pallidus and putamen. Since all these nuclei are present at the base of the forebrain, and that is the reason we call it as basal ganglia. Ganglia, as we all know, is cluster of cells, cluster of neurons. Since all these nuclei, they are located at the base of the forebrain, so we call them as basal ganglia. So we have discussed the components of the basal ganglia. Now, what are the functions of these gray matter areas? So the first and foremost is the role of basal ganglia in cognitive control of motor movements. When we use the term cognition, cognition in simple words means thinking. So when you think deeply, when you contemplate something, you are using this part of basal ganglia for the control of motor activity. Then it not only cognitively controls the motor movement but also executes the pattern of that particular movement, how you are going to perform that particular movement. So voluntary control execution is there. Then comes the timing and scaling the intensity of movement. It not only times the movement but also scales the intensity of movement. For example, when you draw any diagram or figure with the help of your fingers with the pen, such particular movements, in such particular movements, basal ganglia are involved. Another important function of basal ganglia is planning and programming of movement. Before you perform that actual movement, before performance, you plan or pre-plan or program that particular movement. So all these movements are controlled by the basal ganglia. Cognition part is done, execution of the pattern is done, timing and scaling of intensity of movement is being done, and then it plans the movement, it programs the movement, and eventually it will convert thoughts into voluntary actions. So before planning is done, then this will be converted into true or actual voluntary movement. It will convert the intended movement into actual voluntary action. Another function of basal ganglia is its role in regulation of subconscious movements. Not only helps in the regulation of voluntary, but sometimes involuntary subconscious movements are also controlled. Moreover, there is some role of basal ganglia in control of reflex muscular activity. For example, during stretch reflexes, some sort of contribution is there by the basal ganglia as well. Since the basal ganglia they contribute in maintaining skeletal muscle tone, that is the reason they also play their part in control of postural movements of the body. And the primary effect on the skeletal muscle tone is to decrease the muscle tone below the normal level. So, an inhibitory effect is there on the skeletal muscle tone from the basal ganglia. So, this inhibition is provided by the basal ganglia. Hence, the muscle tone is kept in check. Then comes the role of basal ganglia in control of automatic associated movements. And the primary example, classical example of automatic associated movement is the movement of facial muscles during facial expression. Moreover, another example is swinging of arms during walking. All these are controlled by the basal ganglia. So control of automatic associated movements. All these are associated movements, and all these are controlled by basal ganglia. Moreover, there is role of basal ganglia in arousal, and multiple neurotransmitters are also released by this basal ganglia. So we will discuss what are the different types of neurotransmitters released by the basal ganglia. Some of these neurotransmitters are excitatory in nature, others are inhibitory in nature. The important neurotransmitters include dopamine. Dopamine is very important neurotransmitter released from this basal ganglia. It is an inhibitory neurotransmitter, and this is released from the substantia nigra. If you remember, one of the components of basal ganglia is substantia nigra, and substantia nigra is responsible for release of this inhibitory neurotransmitter. Remember, this is inhibitory neurotransmitter. Another inhibitory neurotransmitter released from the basal ganglia is gamma amino butyric acid, or we can write it as GABA, GABA, where GABA stands for gamma amino butyric acid. So GABA is yet another inhibitory neurotransmitter. So besides dopamine and GABA, another inhibitory neurotransmitter is serotonin, not mentioned in this list. Then there are some excitatory neurotransmitters like acetylcholine, substance P, enkephalin, noradrenaline, and glutamic acid. For you people, the role of acetylcholine is important. Acetylcholine is again an excitatory neurotransmitter. Moreover, another important excitatory neurotransmitter is glutamic acid, commonly known as glutamate. So glutamate, acetylcholine, all are excitatory neurotransmitters. Now in this figure you can see the neuronal pathway and how each neurotransmitter is released from its particular site. We will start from the dopamine here. As you can see, dopamine is one of the inhibitory neurotransmitters. So this is inhibitory neurotransmitter. This negative sign indicates inhibition. And from where it is released? From the substantia nigra. This is the portion of basal ganglia from where the dopamine neurotransmitter will be released. As you can see the direction of the arrows, it is released from the substantia nigra, and then these fibers, they go towards the caudate nucleus and the putamen nucleus. So caudate and putamen. So fibers from substantia nigra, they are entering both caudate nucleus and putamen nucleus. So very important inhibitory neurotransmitter, dopamine, released from substantia nigra. Then comes the inhibitory neurotransmitter, gamma amino butyric acid. As you can see, this gamma amino butyric acid, it is released from the same caudate nucleus and putamen nucleus. From caudate nucleus and putamen nucleus, the fibers, they are going back to the globus pallidus. This is globus pallidus. This yellow region is globus pallidus, and some fibers, they enter the substantia nigra. So GABA is yet another inhibitory neurotransmitter. And the third neurotransmitter is excitatory in nature. This positive sign indicates excitation. So acetylcholine is the excitatory neurotransmitter, and this excitatory neurotransmitter is released from the cerebral cortex, and then the fibers, they enter to the caudate nucleus as well as to the putamen nucleus. There are other neurotransmitters like norepinephrine, serotonin, enkephalins. All these are neurotransmitters of basal ganglia. But the important neurotransmitters include dopamine, GABA, and acetylcholine. So we have discussed the two important nuclei of basal ganglia, caudate nucleus and putamen nucleus. Now we will discuss the functions of each nucleus one by one. We will start with the putamen nucleus. Putamen is responsible for controlling complex pattern of movements. And these are the examples of complex movements. These highlighted lines are the examples. For example, hammering a nail is a complex movement. Throwing a basketball into the basket, again, a complex movement. All these are complex movements. These are controlled by the putamen nuclei of the basal ganglia. And here in this figure, you can see the neuronal circuitry through which putamen is connected with the other regions of brain. And we will start from the putamen. This is the putamen nucleus here. As you can see, the inputs are coming from the cerebral cortex. The inputs are coming from the motor region, primary motor area, premotor area, prefrontal area, and some of the fibers, they also arise from somatosensory area. So these are the inputs. As you can see the direction of the arrow, these are the inputs from the cerebrum entering the putamen nucleus. From the putamen, the fibers, they enter the globus pallidus. This is the globus pallidus. The two segments of the globus pallidus are shown: internal segment and external segment. And from globus pallidus, some of the fibers they enter the thalamus here and make synapse with the ventroanterior and ventrolateral nuclei within the thalamus. And from the thalamus, the fibers they return to the cerebrum, back to the primary motor cortex. And there are some ancillary fibers. These ancillary fibers they bypass the thalamus through the substantia nigra and subthalamus here. So the fibers from the globus pallidus they will enter the substantia nigra first, and from there to the subthalamus, and then through the thalamus they will eventually go to the primary motor cortex. So remember the mnemonic. Putamen controls the patterns of motor activity, right? So all these complex patterns of motor activities they are controlled by the putamen. For example, cutting a paper with scissors, passing a football, throwing a basketball, all these movements are controlled by putamen. And the other mnemonic is putamen goes to primary motor. Putamen goes to primary motor cortex. From the putamen, the fibers enter the globus pallidus. From globus pallidus to the thalamus, and from thalamus to the primary motor cortex. Please do not forget the ancillary circuit. The ancillary circuit includes the fibers coming from the globus pallidus to the substantia nigra and subthalamus. And eventually these fibers they will enter the thalamus and terminate over the primary motor cortex as well. So this is the putamen circuit. Now we will discuss the caudate circuit. Caudate, remember C for caudate and C for cognition. So caudate nucleus controls the cognitive part of all the motor activities. And the example given in your textbook is respond to a lion approaching towards you. So when you see a lion, you automatically turn away from it and you attempt to climb a tree. So this response is cognitive, and this cognitive control of motor activity is controlled by the caudate nucleus. As far as the neuronal circuitry is concerned, most of it is the same, but there are some differences. One of the distinguishing feature is that there is no role of ancillary circuits. Remember, in caudate circuit, substantia nigra and subthalamus, they are not involved. So the fibers from the globus pallidus, they will bypass these areas, and as you can see from the caudate, the fibers enter the globus pallidus, and bypassing the subthalamus and substantia nigra, they are entering the thalamus directly. So this is the first difference. Not only there is no role of the ancillary circuit, but there is no role of the primary motor cortex as well. So remember, in caudate circuit, there is no role of primary motor cortex. Instead, you can see the fibers, they are coming from the premotor and supplementary motor area, and the site of termination is the same as well. Premotor and supplementary motor area as well as the prefrontal area. So no role of primary motor cortex and no role of the ancillary circuit. Rest of the pathway is the same. So before we proceed further, these are some terminologies that you must remember. These are some clinical terminologies. The first one is ethetosis. So ethetosis is used whenever there is lesion in the globus pallidus. So damage to the globus pallidus will result in continuous writhing movements of the hands or arms. So this is known as athetosis. Similarly, if there is damage to the subthalamic nucleus, this will result in sudden flailing movement of the entire limb. So one section of the body is involved. So half of the body is involved. That is why it is called hemibellismus, movement of half area or half side of the body. And that site of lesion is in the subthalamus. Similarly, whenever there is lesion in the putamen nucleus, this will result again in sudden flicking movements of hands or face. So these are three important terminologies very similar to each other: athetosis, hemibellismus, and chorea. In all these conditions, there is abnormal coordination, abnormal movement of the limbs or face, but the site of lesion is different in each case. For athetosis, the site of lesion is globus pallidus. For hemibellismus, the site of lesion is all right. Can you hear me? So that we can restart. All right, students, we will not waste time. Sorry for the 5-minute interruption. So here's the scenario for you. A 64-year-old man presents to you with complaints of unsteadiness. And as you inquire, his face is expressionless and the gait is shuffling in nature, and there is rigidity and bradykinesia. And investigations revealed that the substantia nigra of this particular individual contains Lewy bodies, and you prescribe levodopa for further treatment. So this is the case of Parkinson's disease. This is how the case presents to you. So classic presentation is there: Parkinson's disease, and James Parkinson, the English surgeon. This gentleman was responsible for describing the term paralysis agitans, which was later called as shaking paralysis or shaking palsy, as he mentioned. So, what is the pathophysiology behind Parkinson's disease? In one line, the substantia nigra, which is responsible for the release of dopamine neurotransmitter, is impaired. So, loss of dopamine neurotransmitter is there whenever there is damage to the substantia nigra. So as you all know, the balance should be there between the inhibitory neurotransmitter dopamine and rest of the excitatory neurotransmitter, especially acetylcholine. So if the balance is disturbed in favor of excessive excitation or over excitation, because the inhibitory neurotransmitter dopamine is no more or the levels are in lesser quantities, this loss of inhibition will result in overexcitation. I repeat, loss of inhibitory neurotransmitter due to damage to the substantia nigra will result in overexcitation or overexcitability. This is the reason there is muscle rigidity. So skeletal muscle rigidity is there, both cogwheel rigidity and lead pipe rigidity. We will discuss what are the two types. How can we differentiate the lead pipe rigidity from cogwheel rigidity? Then comes the role of resting tremors. Again, a sign of overexcitation, resting tremors or pill rolling tremors. So Parkinson's disease, although the exact etiology is unknown, but the hypothesis is that the damage to the substantia nigra leads to decreased levels of dopamine neurotransmitter. This is the most famous hypothesis, the dopamine hypothesis, loss of inhibitory neurotransmitter dopamine. And the classical signs include resting tremors, also known as pill rolling tremors, Bradykinesia. Bradykinesia in simple words means difficulty to start or to initiate any particular movement. Shuffling gait, known as fascinate gait, the skeletal muscles become rigid. Rigidity is there, both cogwheel rigidity and lead pipe rigidity. So the mnemonic is Parkinson traps your body. Tremors, rigidity, both lead pipe rigidity and cogwheel rigidity. Akinesia or bradykinesia. Bradykinesia is difficulty in initiating a movement. Then comes postural instability and fascinate gait or shuffling gait. And this is the Lewy body here. You can see the Lewy body, the eosinophilic inclusions that are seen on histological findings. And this is the depiction of fascinate gait. The steps are short and unsteady. Here you can see pill rolling tremors. Can you see the movement of the thumb over the index finger? Just like you are rolling a pill with the help of your thumb and index finger. So such tremors are present even at resting state. These are resting tremors. Remember, the tremors of cerebellum are different from that of Parkinson's disease. In Parkinson's disease, we have resting tremors. In cerebellar lesion, we have intention tremors. So this is the classical demonstration of pill rolling tremors. As you can see, the thumb is rolling over the index finger. Now this is fascinate gait. You can see short steps. The subject is bent forward, he's leaning forward, and unsteady gait, shuffling gait or fascinate gait is the proper term. Then there is bradykinesia or akinesia. As you can see, difficulty in initiating a movement. There is no continuity. The person is trying to move forward, but as you can see, difficulty in initiating movement is known as bradykinesia. Then comes the cogwheel rigidity. So how can we demonstrate rigidity? This is demonstrated by applying passive force. So this gentleman in white shirt is the subject, and the gentleman on the left side in black shirt is the examiner, and he is passively flexing his elbow joint. Here you can see. So the elbow, it catches at multiple points, just like a cogwheel. One, two, three, four. So multiple jerks. So such rigidity is known as cogwheel rigidity. And if the rigidity is present continuously like this, continuous resistance against passive flexion or passive force, this is lead pipe rigidity. So the hallmark features of Parkinson's disease are resting tremors, number one. These are also known as pill rolling tremors. Then we have shuffling gait, also known as fascinate gait. The gait is unsteady in short steps and the subject is bent forward. Then there is difficulty in initiating movement, known as bradykinesia. And last but not the least, lead pipe rigidity and cogwheel rigidity. So these are the hallmark features of Parkinson's disease. And why these features are present? The single line answer is loss of dopamine due to damage to substantia nigra. Dopamine, as we all know, is an inhibitory neurotransmitter. So loss of inhibition will result in hyperexcitability. I repeat, loss of inhibition due to loss of dopamine will result in hyperexcitability. Due to hyperexcitability, we see tremors, resting tremors, and we also observe rigidity. Now, this figure is taken from Ganong's review of medical physiology. I will request the students to go through the pages of Ganong's physiology. Here you can see the neuronal pathway in a normal individual given on the left side, and the pathway, the neuronal circuitry in a patient of Parkinsonism or Parkinson's disease. Now there are two types of arrows. The ones which are dotted are the inhibitory, and the straight lines, these are the excitatory. So this is substantia nigra. In the center, this is the pars compacta of the substantia nigra. So here, this area is responsible for release of the inhibitory neurotransmitter, that is dopamine. As you can see, substantia nigra is giving an excitatory signal to dopamine 1 receptor and an inhibitory signal to the dopamine type 2 receptor. So both signals are there, excitatory to D1 and inhibitory to D2. And from these dopamine, the signals, they further inhibit the globus pallidus, like this. This globus pallidus is the internal part. This small I indicates the internal segment of the globus pallidus. As we discussed, there are two segments, external and internal. So inhibitory signals are being sent from the putamen to the globus pallidus, both the segments external as well as internal. And from here, the inhibition, or you can say the inhibitory signals are being sent back to the thalamus, and this will give the excitatory signal to the cortex. So a balance is maintained between excitation and inhibition. And if there is damage to this substantia nigra, the balance is shifted in favor of excitation. Why this balance is shifted in favor of excitation? Because there is no more dopamine, no more inhibition by this dopamine. So this is the pathophysiology. This is the mechanism in the neuronal circuitry. So if there is damage to the substantia nigra, the balance between excitation and inhibition, this optimum equilibrium will be disturbed, and this will be tilted in favor of excitability or hyperexcitation. Hence we observe rigidity, hence we observe bradykinesia and other signs. So these are the common causes of Parkinson's disease. The exact cause, as we all know, is not known, and sometimes we label it as idiopathic without any known cause. But the hypothesis is that the damage to substantia nigra causes loss of inhibitory neurotransmitter dopamine. There are some anti-epileptic or antipsychotic drugs as well. These drugs, they can also induce signs of Parkinsonism. Similarly, sometimes brain trauma or brain injury may lead to Parkinsonism, as in case of Muhammad Ali Clay, the boxer. And these are the classical signs. I will highlight the important signs for you. The first important sign is rigidity, which includes both the cogwheel rigidity and the lead pipe rigidity. We have discussed both the types, cogwheel and lead pipe. If there is continuous resistance to flexion, this is lead pipe, and if there is resistance at multiple points, multiple junctions during passive flexion, this is cogwheel. Then comes the resting tremor. Another hallmark feature of Parkinson's disease is resting tremors or pill rolling tremors. We have demonstrated you what is pill rolling tremor. Mind you, this resting tremor is different from the intention tremors of cerebellar lesion. Then there is festinate gait. Festinate gait or shuffling gait. The person is bent forward and he or she walks in small steps. And the last but not the least is bradykinesia or akinesia. The movement is slow, there is difficulty in initiating the movement. So these are the three important signs of Parkinson's disease: rigidity, akinesia, and tremors. And collectively, we call these hallmark features as the triad of Parkinsonism. These three signs are the triad of Parkinson's disease. I repeat: rigidity, akinesia, and tremor. So when you are going to write down the signs of Parkinson's disease, please do not forget to write these three. And the treatment is done by administering the drug that is levodopa. Levodopa is administered because this dopamine, it cannot cross the blood-brain barrier. So dopamine will not be able to cross this barrier. That is the reason we administer levodopa, which can easily cross the blood-brain barrier. And this is the precursor of dopamine. Levodopa is a precursor of dopamine. Eventually, this will be decarboxylated and converted into dopamine. So levodopa is the drug of choice. Other drugs include MAO inhibitors and COMT inhibitors, monoamine oxidase inhibitors, and catecholamine methyl transferase inhibitors. These drugs, they increase the availability of dopamine so that whatever the concentration of dopamine is there within the body, maximum utilization should be done. So this will increase the availability of dopamine and this will not allow the further degradation of dopamine. But the drug of choice is levodopa. Here you can compare the two types of tremors: Parkinson's and cerebellar tremors. So Parkinson tremors are present at rest all the time, whereas intention tremors, they appear when you perform any activity. Similarly, there is pill rolling tremor in Parkinson's disease. In case of cerebellar lesion, the tremors are coarse in nature. When there is no known etiology of tremor, we will label such tremor as essential tremors without any known cause. So these are the important types of tremors that you must remember. So we have discussed the pathophysiology of Parkinson's disease. Now we will move on to another important clinical scenario. So a 48-year-old man presents to you with involuntary movements of arms and legs. So these are the clues: involuntary movements of limbs. Then there is dementia as well. And physical examination revealed involuntary jerky movements, poor concentration or poor attention span, and there is dilatation of the ventricles on MRI. So these are the signs and symptoms. There is history of dementia. There is history of involuntary jerky movements. There is uh, on MRI there is dilatation of the ventricles. So these findings, they indicate to Huntington's chorea, formerly known as Huntington's chorea. Now the preferred terminology is Huntington's disease, named after George Huntington, American physician. So what is Huntington's disease? This is an autosomal dominant disorder. Remember that this is a genetic disorder in which there is damage to the chromosome 4. So this chromosome 4 is responsible, this is associated with the CAG gene. Remember, this CAG gene is involved whenever there is damage to the chromosome number 4. And what happens? The three clinical signs include dementia and involuntary jerky movements. These are the clinical signs. That is why we call it as Huntington's chorea. Chorea means abnormal jerky movements. So abnormal jerky movements are associated with severe dementia. And the two neurotransmitters that are involved in Huntington's disease are number one, GABA, gamma amino butyric acid. So due to damage to the neuronal cells, the neurotransmitter GABA is impaired, and this is an inhibitory neurotransmitter. So loss of inhibition again will lead to involuntary jerky movements. And the other neurotransmitter that is involved is acetylcholine. Acetylcholine, unlike GABA, is an excitatory neurotransmitter. So loss of GABA will lead to chorea, where chorea is involuntary jerky movements, and loss of acetylcholine will lead to dementia. So chorea and dementia are the important signs. And if both the condition, both the signs are present in a single patient, so you will have to put Huntington's disease in your provisional diagnosis. Again, chromosome 4 CAG gene is involved, autosomal recessive disorder. So the mnemonic is the caudate loses acetylcholine and GABA. So CAG gene, caudate loses acetylcholine and GABA. Loss of GABA will cause involuntary jerky movements, and loss of acetylcholine will impair the cognition, will impair the thinking, hence we observe dementia. So this is all for today's session. If there are any questions, please let me know. We still have 2 to 3 minutes. If you have any question, please let me know. We still have a minute or two. All right, if you have no questions, let's summarize the whole session. Today we discussed basal ganglia. Basal ganglia are masses of gray matter scattered within the white matter of cerebrum. Then we discussed the components of basal ganglia, corpus striatum, subthalamic nucleus, and substantia nigra. And we discussed the functions of basal ganglia, the role of basal ganglia in cognition, the role of basal ganglia in controlling the patterns of complex movement, the role in maintenance of skeletal muscle tone, and the role in reflex voluntary movements, as well as the role in subconscious movements. We discussed multiple types of neurotransmitters, excitatory as well as inhibitory, released by the basal ganglia. And then we discussed the two important clinical conditions, Parkinson's disease and Huntington's
सर
chorea or
टाइम ओवर हो गया
Huntington's
लेक्चर
disease.
का, सर वेट कर रहे हैं.
Okay, thank you so much. Allah Hafiz.